Good evening, everybody. Thank you very much for joining us on this webinar on a Friday night. We appreciate everybody taking the time, and we hope that this will be a fruitful discussion. So on behalf of the MRC, I'd like to welcome our speakers and our panelists for coming, and this is going to largely be an educational program to discuss some of the issues that we faced when the South African Commission for Gender Equality issued the statement, which they've now retracted. And so we will rather focus on some of the issues and also discuss some of the issues around good science. I'd like to introduce my co-host, Professor Mark Sateghe, and I'd like him to say a few words. All our bios are on the webinar invitation. So for the sake of time, we're not going to go through all the bios, but you can reference them for yourself. Mike, can you come in and just say a few introductory remarks? Thanks.
Thank you so kindly, and again, thanks to you, Glenda, Ames, Aslam, the panelists and speakers. I think this is an important occasion for us, but I just need to emphasize that the Colleges of Medicine of South Africa is also supportive of this webinar, as expressed by the President Flavia, the Vice President Joanne, and CEO Eric. You know, the reason is, of course, this webinar demonstrates, echoed by Barry Bloom colleagues, that the most important ingredient in all vaccines is trust. And then, of course, that's why we are here to educate each other. And in this evening, we really seek to be transparent and really have a coherent public communication. I do think that, of course, as we look at COVID as a disease with social impact, it requires management that would actually have integration of health, social and economic responses, specifically social medicine unites clinical and public. So I think in this seminar, we'll see that this will underpin the social cohesion that we need and also maintain the trust even when the adverse events occur. And that's an important situation that we need to realize, but that should be based on science and evidence. Of course, for this reason, this platform will obviously hopefully be one of those things that will help government to take correct decisions. And if it's okay, because of the limitation of time agenda, I would therefore go straight to introduce Prof. Priya Somapli, who is the president of the College of Obstetrics and Gynecology and a Senate member of the CMSA. And as we said, the rest is on the web. She will clarify the scientific and clinical issues around this topic. Over to you, Priya.
Thank you, Professor Sateghe. I'm going to share my screen. Thanks. Do you see my screen?
Yes, we can.
Thanks. I'm going to be reviewing some of the evidence for COVID vaccines for persons of reproductive age. I'd like to start by just saying that I've got nothing to disclose. I'm going to be looking at the effects of COVID-19 disease on young women, particularly pregnant women. I'm going to relate some of our other experience that we have with vaccinations in pregnancies. That's particularly the tetanus and pertussis vaccines. I'm going to be going over some of the benefits of COVID vaccines. And then I think we need to ask ourselves whether COVID vaccines cause any harm. The year 2020 will be documented in history as a year in which biomedical science has demonstrated its mastery over infectious agents on a global scale. I think identifying the pathogen, sequencing the SARS-CoV-2 genome, developing rapid diagnostic testing, optimizing treatments, and generating vaccines within the first year of appearance is quite an extraordinary achievement. We've also been able to generate a large volume of data in this short period. However, we must be cautious about how we interpret this data and how we draw conclusions. What we do know, however, is that pregnant women with symptomatic COVID have a higher risk of ICU admission, mechanical ventilation, and death compared to other women in their reproductive years. The vaccines that we have available in South Africa currently are the Pfizer and the J&J vaccines. Pfizer carries the genetic information necessary to manufacture the spike protein of the SARS-CoV-2 virus, and this is the protein found on the surface of the virus. It's important to know that Pfizer is an mRNA vaccine, and mRNA never enters the nucleus, and it's thus not integrated into the DNA. And within hours or days, the mRNA is degraded into the cell cytoplasm. The J&J is a viral vector type of vaccine, and it uses the human adenovirus 26 that's also been modified to be non-replicating. I'm going to talk about some of the effects of COVID-19 on young men and women in reproductive age. We have robust data both from South Africa, the UK, and internationally to inform us of the effects of COVID-19. We know that certain groups are vulnerable, particularly pregnant women above the age of 35, women with a high body mass index, persons with pre-existing medical conditions such as diabetes, hypertension, and if you're pregnant, if you have preeclampsia, you have a higher risk of morbidity and mortality. We've seen in the UK that Black, Asian, or minority ethnic groups have a higher risk of hospitalization. And again, pregnant women in the third trimester are at increased risk of morbidity. Pregnant women are particularly vulnerable, like I said, in the third trimester. And this is because the physiological changes associated with pregnancy are more exaggerated in the third trimester. Women produce higher levels of estrogen and progesterone. This results in edema of the upper respiratory tract and contributes to the higher risk of infections. Additionally, as the uterus expands, the diaphragm is displaced superiorly, and this decreases our lung capacity. So from our data, both locally and internationally, we see that pregnant women are at a higher risk than non-pregnant women in their reproductive age groups of being hospitalized and requiring ICU ventilation and even dying. In pregnancy, women with preeclampsia tend to have more severe COVID infection. Pregnant women are also at risk of hemostatic and thrombotic complications, including acute coronary syndrome. COVID-19 infection is associated with higher cesarean section rates and iatrogenic preterm births. Babies born to mothers with COVID-19 are more likely to be admitted to the neonatal ICU. This is some data from the UK and from South Africa. The UK started administering their vaccines in December 2020, and they've produced this infographic looking at data from the 1st of February 2021 to 30th of September 2021. And during this period, 1,714 pregnant women were admitted to hospital with symptomatic COVID. Of these, 98% of women were unvaccinated. Of the 1,700 women, 235 were admitted to ICU. And again, 98% of women admitted to ICU with COVID infection were unvaccinated. In South Africa, if we look at our maternal mortality ratio, we see that from January 2019 up to about May 2020, our maternal mortality ratio hovered around 100 per 100,000 live births. But we saw a peak in maternal deaths during the first wave of the pandemic, which was July, August 2020, and then a higher peak during the second wave of our pandemic, which was December 2020 to about March 2021. We don't have further maternal mortality data as it still has to be analyzed. Similarly, we saw an increase in perinatal mortality rates during the second wave of our pandemic. What about men? We've now got some evidence that following COVID-19 infection, maternal male testosterone and dihydrotestosterone levels are slightly decreased. There's also COVID-19 infection also affects one's sperm count and sperm quality. We don't have sufficient data on fertility in women with natural cycles, but we do have some information regarding women following IVF cycles. And it's been shown that embryo quality is poorer in women following COVID-19 infections. And it's recommended that women or couples wait about 3 months following COVID-19 infection before they start planning a pregnancy. I'm now going to relate some of our other experience that we have with vaccination in pregnancy. So immunizing pregnant women to protect the mother and infant has been increasingly being used over the last decade. Immunization protects both the mother and infant as well from infection. It's important to note that the newborn's immune system cannot generate antibodies until they're about 2 months old. So vaccination at birth for the young infant is not an option. The only way we can protect our babies at birth is through maternal immunization. And this has been used for more than 2 decades for diseases like tetanus, and recently we've started vaccinating mothers for pertussis, because these neonates only receive their vaccinations at 3 months of birth. So by immunizing the mother during pregnancy, antibodies are then transferred transplacentally to the fetus across the placenta, and once they're born, antibodies are transferred to the infant via breast milk. The amount of antibodies transferred depends on the timing of vaccination, placental function, and the concentration of maternal antibodies. So we've been vaccinating mothers with a tetanus vaccine for over 2 decades, and neonatal tetanus has been eliminated before the year 2000 in the western regions of the world and in Europe, since the year 2000 in large parts of Asia and some parts of Africa, but it's still not eliminated in parts of Africa. So we've got good experience with vaccination in pregnancy, particularly for tetanus, influenza, and pertussis. What are the benefits of some of the COVID vaccines? By administering a COVID vaccine, one can expect a reduction in severe disease, hospitalization, and death. Vaccination also reduces the risk of infection. It potentially reduces the risk in transmission to other vulnerable household members and other members of the public. We have recent data that vaccination protects against long COVID, and there's also a possible reduction in the risk of preterm birth for our pregnant mothers. The neonate will also be protected by passive antibody transfer across the placenta and via breast milk. Do COVID vaccines cause harm? This paper has generated quite a lot of interest over the last few days and the last week. This is a paper by Alison Edelman in New York, and they followed the menstrual cycle patterns of women who were vaccinated compared to women who were not vaccinated. They followed 6 months of menstrual cycle pattern in the study group. In the unvaccinated group, women prospectively recorded their menstrual cycle digitally, and they reported it to the study investigators. In the vaccinated group, women recorded 3 months of menstrual cycle. This was followed by vaccination, and following vaccination, another 3 months of the menstrual cycle patterns were reported by the study participants. So there were 3,900 individuals in the study. About 2,400 were unvaccinated, and 1,500 women were unvaccinated. Women received either the Pfizer, Moderna, or J&J vaccines. And what they found in the study was that in the cycle following COVID-19 vaccination, cycle length increased by 0.7 of a day. So that's less than 1 day, that cycle length increased. This means the number of days between menstruation increased by 0.7 of a day. There was no difference in the menstrual bleeding days or the volume of blood. Following the second dose, cycle length increased by 0.91 of a day. It's important to note that in the US, where the study was performed, the period or the time between the two Pfizer doses is 21 days and 28 days for the Moderna vaccine. South Africa has a longer time frame between the two vaccine doses. So some women received both doses in a single menstrual cycle. And this group of women contributed largely to this difference that has been seen. And if this group of women was removed, there was actually no difference in cycle length between the two groups. It's quite natural that certain stresses in life, physical or hormonal changes, can induce a change in cycle length. And the International Federation for Obstetrics and Gynecology suggests that up to 8 days in cycle length, change in cycle length is actually quite normal. So from the College of Obstetrics and Obstetricians and Gynecologists of South Africa, we actually think that the results of the study are quite reassuring. It may be statistically significant, but it's not clinically relevant. And the effect of vaccination on menstruation is minor and temporary. What about the risk of myocarditis? This is an update from the Advisory Committee on Immunization Practices in the United States. They looked at the incidence of myocarditis following COVID-19 vaccination. And this paper was brought out after more than 30 million vaccine doses were administered in the United States. So 30 million vaccine doses were administered. And what they predict, or the model that they formulated, was that the risk for myocarditis is the highest for young males, particularly in the 12 to 21 age group, but the risk is very small as the men get older. And for females, the risk of myocarditis is extremely small. So if we look at this table, if for men in the age group 12 to 29, for every million doses of vaccines administered, about 11,000 cases of COVID-19 will be prevented. If we look at the older age group, this translates to about 15,300. For every million doses of vaccine administered, 560 hospitalizations will be prevented in the 12 to 29 age group, and 4,500 hospitalizations in the age group above 30. ICU preventions, 138 and 1,200. Deaths, 6, but up to 700 in the age group above 30. One can expect about between 30 and 40 cases of myocarditis in the group of young men, and about 3 to 4 cases in men above 30. It should also be noted that the cases of myocarditis reported were mild. All persons who reported myocarditis recovered, and there were no deaths reported following myocarditis. If we look at women in the age group above 30, 1 million doses will reduce the risk of COVID-19 cases by 14,900, will prevent about 3,400 hospitalizations, about 700 ICU admissions, and about 347 deaths. And the risk of myocarditis in women amongst all age groups is very low. It's less than 5 or 10 per million doses administered. So this advisory committee has come to the conclusion that COVID-19 or MRI vaccinations is still recommended in all age groups, as it will prevent morbidity and mortality from COVID-19. And this far exceeds the number of cases of myocarditis that can be expected. Does the vaccine cause infertility? There is no evidence that COVID-19 vaccine causes infertility in either men or women. We can, however, expect some side effects. There can be some minor local reaction at the injection site, some pain or redness. People can expect some fever or headaches. Rare thrombotic events have been reported following AstraZeneca and J&J vaccines, but again, these numbers are very small. It's about 1 or 2 per several million. And there's no evidence at the moment to suggest that the vaccine causes any harm to the fetus. So in conclusion, COVID-19 vaccine is safe. It does not affect a woman's body in a negative way. It does provide protection, and it's important for us to get our population vaccinated if we want to return to social, educational, or extracurricular activities. And at this stage of the pandemic, the benefits of vaccination far outweigh the risks. Thank you.
Thanks very much for that overview. Just to remind everybody that if you do have any questions, please post them in the Q&A section and not in the chat, so that we could get people to answer them with any specific questions. So thank you very much for that, for clarifying the scientific and clinical issues. We're now going to go on to Lebogang Ramafoko, who's going to talk about hazards to reproductive rights and health. Her bio is in the program, and we're very privileged to have her on. And so thank you very much, Lebo. I'm going to ask you to show yourself. There you are, and continue. Thank you very much.
Thank you very much, and thank you for inviting me to this panel. And it was really good to hear the comments that were made earlier about the research that we have done and what the science is telling us. I think for me, I approach sexual and reproductive health from a rights-based perspective and from a justice-based perspective. And for that reason, I really want to really say that the initial press statement from the CGE was not only disheartening, but it was enraging. I feel that it was opportunistic. I think it was a distraction, and in a lot of ways disingenuous, because I say these words as somebody who has been an activist in this field for a very long time, and I did not choose these words lightly. And I will then elaborate on why I feel this way, because this is not only a matter of scientific pandering, but it is a matter of our response as an African nation, and the issue of who has borne the brunt of COVID, let alone from a perspective of who's got access to vaccines and who does not. And it remains in a country like ours, the marginalized, it remains women, it remains queer people, it remains the poor. And where we are already dealing with massive disinformation and inequitable access to health commodities such as vaccines, I actually really take exception to the statement that was made. And these are my reasons. First and foremost, I think all of us who are working in any field of activism, and certainly in public health, in science, know of the principle of do no harm. That what we need to do, even as we share our concerns, is that whatever that we do is the principle of do no harm. And I find it very disheartening that a body like the CGE, which is supposed to really be at the vanguard of making sure that no additional harm is made to women, particularly poor women, particularly queer bodies, and all the marginalized, has basically participated in causing harm. And I don't think that this is harm that we must take very lightly. And I say that it was disingenuous because I can think of so many things to do when one reads a study, one study, as we have heard in the previous presentation, that suggests that there could be any form of harm. I would want to believe, as a South African, as a woman, as an activist, as a sexual and reproductive rights and justice activist who has spent 30 years in the field, that there are a number of things that you would do. And the number of things that you would do is firstly to recognize that there are so many bodies, and that as a country, in fact, we have done very well in bringing all the science to bear. And for the first time, unlike when we had the AIDS pandemic, we've had a government that has grappled with the science, that have brought the science to the fore. There has not been always consensus, but at least there has been moments of solidarity where we were responding to a global pandemic using the science that is available to us. And the fact that there wasn't an engagement, therefore, with our own local scientists and privately raising the concerns that the CGE may have had really tramples on the justice that the CGE purports to protect. And I say that because what we have seen, and I think when the country spoke about the identification of Omicron in December, we have actually seen the kind of Afro-pessimism that we have in the global world about the coronavirus. Within minutes, it was politicized and it was even called a South African virus. And in a lot of ways, we should know when we deal with issues of gender that narrative and representation are very important. And we know what it took for our scientists and everybody to actually change that narrative, which was mainly a very Afro-pessimistic narrative about Omicron, when in fact our success and our groundbreaking science and our solidarity with the world was then taken to punish us. And we have seen what that has done to our world. We also know that we are facing vaccine apartheid, where many activists, some of them who were even active during the time of HIV, some of them who attacked and challenged some of the major issues that we have about the behavior of the world in the global south, in the global north, and also about the behavior of big pharma. We know what the effort has been, coupled with our government, coupled with our scientists, to really address the whole issue of vaccine hoarding, when in fact the very people who need the vaccine are kept out by the behavior of the global north to hoard vaccines and probably put at risk many, many communities. And when we know, particularly in a country like South Africa with inequity, we know that when we say that people will be locked out, we do know that it is mainly going to be the poor and the marginalized, even in our own country. And I think for me, what I find very regrettable about this is that people died. Behind every statistic is the people who died. 2020 is not that far away. And I think we must cast and maybe even hold a moment of silence for the many healthcare workers who died, for men and women when there was no vaccine, when all we knew was that we must stay home and wear a mask and wash our hands and sanitize, still braved the world and watched our own loved ones die. The majority of these are Black women, because we do know that even in the medical fraternity, the people who are at the coal face of dealing with patients and patients' care are healthcare workers. It is the community healthcare workers whose labor is not protected, who are going into communities. At Tikano, we hosted a webinar with community health workers who some of them were talking about incidents of even being raped when we go into homes to tell people to wear masks. We supported a number of fellows who would then make sure that the disabled get food. So for me, I call it opportunistic, because the voice of the CGE was missing at the time when our healthcare workers, mainly Black women, our community health workers, were walking and working to make sure that everybody in South Africa uses the non-pharmaceutical measures to protect us from HIV. These are not statistics. I want to remind us, because the CGE is a public institution with a particular mandate, and I'm not going to even get into what that mandate is about where we missed the voice of the CGE. During the level 5 lockdown, shops like Checkers and other big retailers could trade. That was the only place where we could all go and get food. However, hawkers, informal traders, sex workers, the unhoused, or those that did not have housing, had to be at home. The images of many hawkers in Johannesburg standing outside the City of Johannesburg offices so that they can get permits to be able to trade still haunt me up to today. And anybody, whether it's a body as an institution or it's a body as an individual activist, should be worried and should still have that image in their minds about how, in dealing with COVID and in having a level 5 lockdown, those that were more vulnerable, like domestic workers, could not work. And in fact, it was basically the retailers who work. Let's think back of our hospitality industry and how many women, how many waiters, how many people whose livelihood in South Africa, where 60% of children are in single-headed households, mainly headed by poor women who eke their income from scrubbing the floors, could not go to work. We missed the CGE sorely at that time. We missed the CGE going to the media. We missed the CGE advocating for the vulnerable. We missed the CGE advocating for the homeless. And I think if we really are going to make this an issue of solidarity, an issue of equity, we need to be saying what it is that each and every one can do. I think it's very easy, and we have seen it, to spread disinformation. It is very easy to go onto media and onto Twitter, even as a citizen, and basically raise some of these concerns. But what is our responsibility? And I go back to that first principle of do no harm. I've got a thyroid condition. I've got an inactive, let alone underactive thyroid condition. Every morning I take the pill. There is a big leaflet in the packet of tablets that I use that tells me what the side effects are. And I'm very glad that the initial presentation spoke about, even with COVID, what are the benefits that basically outweigh the risks. Anybody who at any point in time, including this morning, took paracetamol could suffer the risks, because there are side effects, even on medications like Panado. But again, we basically weigh what are the benefits. And therefore, I bring back where we missed the CGE, because at this time, as gender activists, as feminists, as sexual and reproductive rights activists, what we need to ensure is to make sure that sex workers, our job in the fight against COVID, is to make sure that sex workers are vaccinated, is to make sure that the undocumented are vaccinated, is to make sure that the homeless are vaccinated, is to make sure that hawkers are vaccinated. And I think it is so disheartening, so that instead of saying, now that there is science, now that there is a vaccine, which the privileged are going to get by virtue of being privileged, how are we going in our mandate as the CGE to make sure that those that are always and often left out in the margins to fend for themselves are going to be vaccinated? So I find the statement extremely problematic and enraging. I also think that what we also needed the CGE to do, and why this is not only an issue of sexual and reproductive rights, but it is an issue of our right as Africans in a global narrative about our contribution, not only as a country, not only as a people, but also as a people in the global south, was we missed the CGE in really sending statements to the various countries about supporting our scientists. We have produced some of the most cutting edge science. where we have pledged solidarity, not only with WHO, not only in those structures, but we have shown through our science with other countries in the global north, including Latin America. And if we are dealing with something like what the science has shown right now, which is the best biomedical intervention, with the science that we have, the best that we have right now, produced by the best science that South Africa has produced. Why are we having this destruction? Why are we feeding, into the pseudoscience? How is this different from the AIDS denialism that we basically had in the past? Lest we forget that we are where we are as civil society, because even with HIV, many people died. I want to underscore it. We are where we are because men and women and children, Black men and women and children paid with their lives. The benefit that we have, that as a country, we can talk about rights, we can talk about having a say and a space in the global stage. The advancements in science that we have, the drugs that we have that have made HIV a chronic illness, in some instances better managed than other chronic illnesses, came at the price. And so for me, I really invoke that because these statements do not happen in a vacuum. And the harm that they cause is not only hesitancy. I think they spit at the grave of everybody who has sacrificed their lives. I wish there was time for us to mention each and every health worker, including community health worker, including cleaner, including those that were pediatrics and specialized workers. I don't think as a country, we have even calculated what the cost of what we lost when we did not have vaccines is. This, ladies and gentlemen, is a matter of life and death. And I personally feel very enraged that instead of enjoying my Friday evening, I am sitting here and I am, instead of following the science that many of our scientists have worked tirelessly to do, studies to present. We had a government that stopped the rollout of J&J because 6 people had presented with blood clots. That is the evidence. And I don't know where the evidence for the CG is. But I also know, and it is something that I want to talk about, because I think the one thing that we need to ask ourselves as people who are advancing and speaking for the cause of the marginalized is to ask ourselves that today, on the 28th of January, 2022, we need to ask ourselves, who is the CGE? And I want to say this because I personally, as a social justice activist, do not want to be silenced. Because, like most Chapter 9 institutions, we have seen reports starting from last year of the state of the CGE right now. And I do not want us to not speak about the context in which some of these press statements have come out. We know that there have been reports in the media of meddling by commissioners, including the Oversight Committee, in day-to-day operational issues at the CGE. We do know that the CGE has been paralyzed by internal politics within the CDE. And I'm deliberate in mentioning this because we have watched at this country and it looked like a soap opera when we went to the state capture and we knew what happened to resources, including the reports of the SIU about what happened with the money that went to PPE that did not reach people. So it will be amiss to speak about the fight for social justice, it will be amiss to speak about the fight for social and reproductive justice when you do not question who are the organs that purport to speak in our name. I think the only good thing that has come out of this is the fact that we are re-engaging with science. But more importantly, as a social justice gender activist who has really worked in this field for many years, is that the one thing that has come out of this is the pointing out of the real trouble that the CGE is at. And I hope that over and above this webinar, we are going to actually ask the most important question. I think the science and the scientists, as regrettable as it is, as regrettable as it is that their statement contributed to vaccine hesitancy, as women in this country, where the statistics of GBV are the way that we are, we need to ask ourselves, who is the CGE right now? And what is happening from the Oversight Portfolio Committee? Very soon, commissioners are going to be attended. It's an open secret, and I can speak about it because we know that the commissioners that come onto the CGE, there is a lot of meddling from political parties, in fact, mainly by the ruling party about who becomes a commissioner and who does not become a commissioner. And I want to say in conclusion that this CGE that issued the statement did not make an error. I know that they have issued a statement, and I stand and I want to be on record to be saying an error is, I don't know, when you don't unmute yourself when you are on Zoom. That's an error. An error is probably when you show to an online meeting in your pajamas. It is not an error when you do not engage with the brilliant science that exists in South Africa, when you do not understand and even show the humility, because we all saw the interview that was conducted. You don't engage. You don't even recognize that there are people out there who have engaged, who have made it their livelihood to secure our livelihood. And you go out and you issue a press statement. Our principle is first do no harm. It is not an error. And I think for me, we need to ask ourselves, who is the CGE? And I want to state categorically that, in fact, what patriarchy does, because all of these institutions are very patriarchal, is that patriarchy is very good at destruction. The statement was opportunistic because, in fact, it represented a particular fight that has got nothing to do with vaccines. So let's speak the truth. Let us say that this is it's actually not only disheartening, but enraged. And in closing, I want to say the CGE that issued this statement is not the CGE that represents the needs and the wants of women. Where is the focus groups that they have done with women in South Africa? Where is the engagement that they did before they went to the press? So I don't think that it is an error, but I will end there in the interest of time. Thank you.
Thank you so kindly, Lebo. That was really a passionate talk and clearly demonstrating that we have to rely on science, collaborations, consultation, and therefore we can in that way offer coherent public communication and take into consideration the socioeconomic status of our country, of course. And then this follows through nicely with the talk that's going to be by Kanisa Mapipa, speaking about Chapter 9 institutions, the mandate and purpose. Over to you, Kani, if you can try to also keep on time as well.
Yes. Thanks, Mike, and thank you to the SAMRC for having us as Section 27. So there are 6 institutions that are established by Chapter 9 of the Constitutions, and they're obviously commonly referred to as Chapter 9 institutions, and these are the South African Human Rights Commission, the Public Protector, the Commission for Gender Equality, the Commission for the Promotion and Protection of Rights of Cultural and Religious and Linguistic Communities, and the Auditor General, and as well as the Electoral Commission. The purpose of these Chapter 9 institutions is to protect and to promote human rights and to support the development of our constitutional democracy. These institutions are separate from our government, and they're separate from our government in that they do not exercise their powers in the same ways that the judiciary exercises its powers, that the legislature exercises its powers, or that the executive exercises its powers, but rather they are independently and impartially there to guard against the infringement of rights in the Bill of Rights. Section 181 of the Constitution, which establishes and sets out the governing principles of Chapter 9 institutions, states that fundamentally these institutions are independent, subject to the Constitution and the law. They should be impartial and must exercise their powers and perform their functions without fear, favor, or prejudice. Each of these Chapter 9 institutions have their own specific mandate, which is set out in the Constitution under sections 182 to 188. And also their respective regulating legislation, they have their mandates also set out in there. But broadly and briefly speaking, the Public Protector guards against maladministration of state funds, by state officials. The South African Human Rights Commission guards against the abuse of human rights, and the Commission for Gender Equality guards against or protects gender rights. The Electoral Commission ensures that we have free and fair elections, and the Auditor General ensures accountability when it comes to state funds, and the CRL Commission, the Commission for the Protection and Promotion of Culture, Religion and Linguistic Rights, it is charged with protecting and promoting the rights that protect our diversity. These institutions provide and protect, these institutions are the checks and balances that ensure the transformation of South Africa into a society where social justice prevails and the rights and the rights in the Bill of Rights are respected. When you look at the individual mandates of each of the Chapter 9 institutions, you can generally group them into two groups. Their respective responsibilities can fall under the first being monitoring and evaluation and ensuring state accountability. This they do through their powers of investigating, their powers of monitoring, and taking the necessary steps to ensure appropriate redress where human rights have been violated. The second group is participating in the development of a transformed South Africa, and this they do through their powers of educating the public on their rights, carrying out research, lobbying and advocating for human rights. So the rights and the responsibilities and the mandate of the Chapter 9 institutions, including the CGE, can be grouped into monitoring and evaluation, and ensuring state accountability and participating in the development of a transformed South Africa. Chapter 9 institutions, so if we take the 6 Chapter 9 institutions, we have 3 of them that are specifically that relate to ensuring the protection of human rights. This is the South African Human Rights Commission, the Commission for Gender Equality, and the CRL Commission. And I say that these are the Human Rights Commission or Human Rights Chapter 9 institutions because their mandates and their responsibilities are quite similar, and they often overlap. So you have the South African Human Rights Commission, who has the broadest mandate, and then you have the Commission for Gender Equality and the Commission for Cultural, for the promotion and protection of cultural, religious and linguistic rights. And these two, the Commission for Gender Equality and the CRL Commission, support or supplement the South African Human Rights Commission's mandate. Now, the mandate of these human rights Chapter 9 institutions, and including the mandate of the Commission for Gender Equality, also have a broader, are also broader in the sense that they also include or extend to the private sector. So they extend not only to the state in the sense of the public protector and the auditor general, but they extend to the private sector as well. So they are for the entire country or every citizen. So if you consider the implementation of their mandates, what must guide these, as I've previously alluded to, is independence, accountability, or independence, impartiality, and the exercise of power without fear, favor, or prejudice. And this means that any preconceived opinions or notions which are not based on fact, reason, or actual experience must be disregarded in the application of its powers. In addition, when implementing its mandates, Chapter 9 institutions such as the CGE must be sensitive to the fact that the rights in the Bill of Rights are not absolute and are subject to limitation, and that these rights must be balanced against other rights in the Constitution. Thank you.
Thank you very much. That was excellent, and gave us a nice overview for giving us what Chapter 9 institutions should be doing and what their mandate is. So thank you very much for that. We're now going to move on to our panel discussion, and we'll probably spend the next 30 minutes or so asking for input, and then we'll go to some of the question and answers. But I'd like to first of all, we're going to ask Linda Gail Becker, Angelique Coetzee, and Despina Demopoulos to come forward and have it and say a few words, and then we're going to have Busi from the CGE to also give some input after that. Thanks, Linda Gail. Maybe we'll start off with you.
Thanks, Glenda, and just really very happy to be on this panel, an important one, and I thank our previous speakers who I think really laid the scene extraordinarily well. Huge claps for Lebogang, who I think really sang to my heart in terms of some of the thoughts that have gone through my head this week. But I'm an infectious diseases doctor and a vaccinologist. And as such, I thought I would just highlight a few points that I think were made very well by Priya. The first is that there is indeed a large and growing body of evidence that COVID-19 is bad news for women of reproductive age, particularly those who are pregnant. It increases morbidity and mortality in pregnant women, and we know that we have poorer outcomes in the neonates that they are carrying, resulting in preterm deliveries and other poorer outcomes. So the evidence is so strong, in fact, even in the short 2 years that we've been living with COVID-19, that most bodies around the world that weigh up what we should be doing around in the field of obstetrics, gynecology, neonatology, have come out very strongly in favor of vaccinations, COVID-19 vaccinations in this population. Now, I think it was beautifully said by Lebogang, all sorts of pharmaceutical agents we have concern about. Our policy is do no harm first. And so as such, we often much prefer to err on the side of no pharmaceutical agents of any kind for preconception and first trimester women. However, as I say, around the world, every body that I have looked at, every agency that weighs in on this has come out very strongly to say that we should be in favor of COVID-19 vaccination for pregnant women, pre-conception, during pregnancy, and immediately post-conception, because of this increased risk for them should they go down with COVID-19. So then I asked myself, well, why did Edelman and others conduct this research? You know, where were they going with the research that was highlighted so much by the CGE? And the way I interpret the paper, having read it all the way through a couple of times, as I hope most people have, including the CGE, that I think it was really, you know, in the face of vaccine hesitancy, where it has been cited around the potential impact on fertility that COVID-19 vaccines may have, and some concerns about menstruation that have been raised. I think the paper is incredibly balanced. I think it is well done. And the authors find a small but really insignificant impact on menstrual cycles, menses length, etc. So the paper comes out actually contrary to the way it was described by the CGE as a reassurance that, and dispels many of the fears around fertility impact. So that is the way I read it. And I think this is really what we want to put out there to, if people still have lingering questions about the paper, is that if anything, it really reassures us all that COVID-19 vaccines for this population is the way to go, and that we should be really recommending and encouraging women in this age group of 18 to 45. Marian, I've seen your question, and maybe we can come back to it in the question section, that women over the age of 45, those that are many peri and postmenopausal, are often overlooked. Unfortunately, in this paper, again, we looked at the women of reproductive age. But I think in this age group, we can really be reassured that vaccination is really the way to go. And, you know, I cannot underpin more what has been said by the panelists or the speakers before me, that really the recommendation is that we don't cherry pick papers, but we look at the body of evidence that is available to us in order to make our statements. This is such a critical time. And again, I want to say, having looked at all the evidence out there, the recommendation firmly and incontrovertibly is in favor of COVID-19 vaccination for pregnant women in order to impact outcomes in this during this pandemic. Thank you.
Thanks very much. Angelique, over to you. And then we'll have Despina and then Bosisiwe.
Thank you so much for having Salma here tonight as well, or for me representing Salma. Wow, it's all that I can say. You know, we had such powerful presentations so far, and as a female and a woman of past age bearing, I understand the need for these vaccines, and it's very interesting. A lot of my patients that are pregnant coming into the surgery, I will ask them, have you been vaccinated? And the answer is actually no. And then I would ask, have your gynecologist discussed this with you? And in 99% of cases, the answer will be yes. But there's a fear from these pregnant women that the vaccines might hurt the fetus. And, you know, I'm then trying to tell them to say, listen, the studies are out there showing that the mother, especially in the last trimester, 2 or 3 weeks before giving birth, are actually a high risk of getting COVID-19 and ending up in ICU, and some females also lose their lives. And who is then going to look after your baby? You know, I think there's such a lack of information around getting vaccinated, and that the vaccines can actually protect the baby as well. So we are far away from trying to get these pregnant women to be vaccinated. And the last thing that we need is then having information being spread out there. So SAMA strongly recognizes that medical practice and public health policy, for instance, the COVID-19 vaccine rollout, must be evidence-based and guided by the latest and best available scientific knowledge. And we also have a critical role of guiding the public and countering misinformation, especially pre, during, and post-COVID. This is, you know, it is such a sad state of affairs. If we look at our vaccination progress today, we can see that South Africa is lagging behind most countries globally, and we have missed our vaccine target by being only about 28% of South Africa has been vaccinated. Globally, it's a 53%. And one of the biggest contributing factors is vaccine hesitancy. And we need to get the message out there. And again, how? By suspicion on the rapid speed of vaccines development, the mistrust of the South African government, who is a champion of the vaccination program and advocate of mandatory vaccination, then the public ignorance and the epidemic of fake news out there, the abuse of social and mainstream media, the misinterpretation of scientific findings, all of that contribute. And then we have voices of powerful groups or individuals expressing their opinions on vaccines or questioning the science, resulting further in this public confusion, as Lebo has so kindly showed us. And we cannot, again, afford it, not in this current pandemic, not in the current state of affairs that our economy are, and having young people not taking the vaccines, having people thinking that menstruation is going to be affected by vaccines, that fertility is going to be affected by vaccines. And I think it was Prof. Brida that shows us that your infertility is not going to be affected. And if I'm not mistaken, there was 2 studies actually showing better sperm count after being vaccinated. So we need to understand that that if you speak against the vaccines, not based on fact, that we will get an even lower vaccine uptake. And that low vaccine uptake, we know it is identified as a risk factor for mutation or evolution of a vaccine-resistant strain. And we cannot afford it. So it is important, and I thank Prof. Ames Dye, Prof. Linda Gray, and Glenda Gray, and all the other panelists here tonight. And also Aslam, although he's a male, it doesn't matter. He also played a very vital role in starting this program, where we implemented effective communication and education, and where we raised our voice in a letter that was sent to the minister and out there. And that I applaud the group here tonight for taking the first steps into that and showing that solidarity in matters related to and affecting all of us, how by standing together in solidarity, how much we can achieve. And also going out there and say, vaccines are necessary, it's safe, it's effective. SAPRA is the watchdog on safety and effectiveness. Millions of people have been vaccinated so safely. And we have to stand together. And again, I also would like to emphasize what Lebe was saying. We should be very careful before we go out there and make public announcements around matters that we know will have a huge effect, like menstruation, like pregnancy, and then trying to say that it was an error. We should not do that. Going forward, I am going to ask this watchdog group that we have here tonight, who signed those documents, please let us be vigilant. Please let us make sure and hold people accountable going forward to what they are saying. I thank you.
Thank you very much, Angelique. We're going to ask Despina. I'm going to give you 3 minutes, and then we'll ask Busi to come on. So sorry, I'm going to rush the panel a bit because we seem to be running out of time. Thanks.
Not a problem. Thank you very much, Glenda, Ames, and the whole team for having SAPA allowing me to represent SAPA here tonight. So SAPA is the South African Pediatric Association, and our focus is on the well-being of all children, and obviously the well-being of children very much includes their parents and the mom and the reproductive health of the mother. So quite early in the pandemic, SAPA began issuing position statements with regards to the well-being of children. And at the beginning, it started off with position statements encouraging children to return to school, routine health services to women and children to continue, and very much a focus on the collateral damage to children and their families. And we realized quite early on that statements are quite important, and that if they're done correctly and are evidence-based and distributed correctly, it could make a huge difference. And quite early in the pandemic, our statements landed up in many pediatricians' offices and on lots of social media websites, and helped, we believe, get a lot of children back to school and back to their clinics and vaccinations, as we realized this was a problem. And then on the 25th of October last year, we actually released a position statement together with our obstetrician colleagues, because we realized that there was a huge problem with regards to pregnant women getting vaccinated. And this was actually obviously affecting our neonates and our children. So the position statement that was issued basically said that we promote and we definitely encourage pregnant and lactating women to get vaccinated, as we know that COVID can increase the risk of prematurity. You saw from the UK data that Prof. Priya Pillay showed 20% admission into the neonatal ICUs. And we know that, as with the other vaccines in the past, that there is definitely an improvement, or we hope there's a transfer of the SARS-CoV-2 antibodies to the infant, and we feel that that will help. So just quickly, in terms of the South Africa, what's been going on, we have seen that our newborns have definitely been affected. And a lot of the kids that have landed up in the ICUs have been small babies, newborns, preemies, who then develop chronic lung. So COVID does have an impact on the children too. And for that reason, we are very much promoting the vaccine for pregnant and lactating women. So just quickly, with regards to the statement, so the South African Pediatric Association really was concerned and really are very happy that the CGE is actually going to retract the statement, because this affects not only the pregnant women, but also the unborn babies. And we know that COVID has done huge harm to our children, and not always in terms of them being sick and being admitted, but children have suffered during this pandemic. They've suffered because they've been away from their mothers, sometimes straight after they've been born. Initially, at the beginning of the pandemic, we thought we should separate them, which was also incorrect. We decreased breastfeeding when the moms were pregnant. I mean, horrible things that happened to our children. And then there was all the collateral damage that came with COVID that affected the children mentally, socially, and a whole lot of other stuff. So the South African Pediatric Association really promotes the vaccination of pregnant and lactating women. And we know that this will definitely help outcomes in terms of prematurity with kids with moms or COVID, and definitely improve the outcomes in the neonatal ICU related to COVID. So thank you for hearing our voice, and thank you to the CGE for retracting that statement. And we have learned that statements make a huge difference. So SAPA's motto is striving for thriving kids, but our kids can't thrive without their mothers and their fathers. So please, can we encourage that always? Thank you.
Thanks very much. So I think our final, we'll see if there's any time to do questions, but the final panel panelist that's going to talk will be Busi from the CGE. Thank you.
Thank you, Prof. Gray, and thank you for the invitation to come and reiterate the retraction. I think that the mandate that I have from the Office of the Chairperson is to sincerely apologize to health workers and the health worker community that the January 16 about and on the harm that the January 16th statement has caused. We do acknowledge the added work, emotional, human, financial resource work that has had to go into addressing the potential detrimental effects that the initial January 16th statement has made. We also want to ensure that we reaffirm the CGE's commitment to addressing the potential misinformation, not merely by issuing a retraction, but by taking concomitant action that will address under our educational mandate, that will address some of the misinformation that might have gotten out there. And hopefully this also presents an opportunity for us to receive the information that we need to receive, and to note the various associations that we can go to help us put together a communications package that will indeed address some of the miscommunications and some of the issues that might have arisen as a result of the January 16th statement. The retraction reiterates that the work of the CGE is to ensure the fostering of democracy through the recognition of and the addressing of gender inequalities. Part of that is looking into sexual and reproductive health of women and people with wombs and other gender minorities. And that is a function, and that is a mandate that we continue to adhere to. However, we do have to acknowledge that this process requires a threading carefully where we do not have the expertise, and where we do fall short, it requires a leadership that is reflective, a leadership that is accountable, and a leadership that acknowledges that when things have gone wrong, we can stand in front of the communities that we have impacted, and we can seek to provide redress through accountable action. So I do want to reiterate, I do want to bring forward the apology that comes from the Office of the Chairperson, and I do want to ask for the continued support, whether it's through calling out or whether it's through supporting some of our initiatives as the CGE. We are indebted to the health worker community in helping us through the COVID-19 crisis, and ensuring that the South African public continues to be informed, continues to be given the best information that is out there in the world. And we do want to acknowledge it. And I think those are very important considerations. I will take questions and comments and address those as we go through. But those are the words that I would like to provide and to emphasize that the retraction doesn't only come with mere a statement, but there is an intention to take proactive steps to address the misinformation and any negative and impact that the January 16th statement may have had on the South African public and on vaccine hesitancy. Thank you very much.
Thanks. I mean, thanks for the remedial action. I hope that we have emphasized that pregnant women have adverse outcomes when it comes to COVID-19, and we hope that that we've emphasized how important vaccination is for this group, and that we've also emphasized as well that there's no impact on fertility, and that a stance of the CGE on this has done harm. Lebogang has said, and she says it again, that why was the statement issued, and what was the whole rationale of engaging in a statement like that without consultation. I think, Lebogang, am I summarizing you? I think you want to ask a question. Am I summarizing what you want? But I'm happy for you to ask the question directly if I've got it wrong.
I think you are. And with all due respect, Busi, it was damaging. All the science we listened to today existed even before you issued the statement. So the whole issue that you will get help, you are not victims here. The CGE is not the victim. The CGE did a deliberate act. And I think even the phrasing of, what happened does not underlie the power that you have, the responsibility that you have, and the damage that you have caused. I mean, all of this could have happened outside of the eye of the most marginalized in terms of not it being a press statement. You could have sat with all of the scientists. You could have said, yes, we are concerned about the study that we have picked up, and all of the scientific information that was shared here could have been shared before. I don't think that as a citizen, we need to be saying we need to help you with messaging. This feels like digital vibes. There are expert organizations with a proven track record in South Africa to do messaging. If you don't know how to do messaging, you first do no harm. I'm pushing back. I think it is mild, and I think the language is that of, maybe help us and stuff like that. It is good to retract. It is good to apologize, but you really need to basically completely understand how damaging it is. The CGE did not make an error. It did not make an error.
So thank you very much. I think I think a lot of us are aghast at the statement, and why there was no consultation with scientists, the Ministerial Advisory Committee, the Department of Health, to clarify before putting forward a statement that does cause vaccine hesitancy and may also harm pregnant women. So Lebogang, we take your outrage because it does concern us, that this further fuels and damages issues around pregnant women. I'm going to. Are we running out of time? And I want to hand over to Mark Seteghe to allow him to introduce the aims and Aslam Dessou for the closing remarks. But before I hand over to him, I just want to thank the panelists and thank everybody for engaging, and also to thank Ames Dye, Professor Ames Dye. If it wasn't for you, we wouldn't be doing this. And we acknowledge and respect all the hard work that you do. And so I also salute you and the work that you've done in this regard. So over to you, Mike. I'm going to let you finish the symposium. Thanks.
Thanks, Linda. And then again, wants to reiterate what we have learned today. I mean, really the importance of working together cannot be elaborated. And really, indeed, again, to underscore the science that that we really have to rely on. And of course, that will really be important for getting the trust that we need for vaccines and the messaging that will go out. But of course, the importance of really this is to really map the way forward. And in doing so, in our closure, we do have two people that needs no introduction, because they've really done a sterling work. We all know that. I mean, Prof. Ames Dai, the chairperson of SAMRC Bioethics Advisory Panel and UNESCO, as well as Dr. Aslam Dasu, the convener of Progressive Health Forum. They've done an excellent work in getting us together here. But of course, they will be having some suggestions of how we can go together forward and not be a once-off webinar. And really, Ames and Aslam, over to you to really forge the way forward.
Thank you very much, Mike, and thank you to the organizers. In particular, thanks to Ames, who very diligently went forward with this event, which I think is a seminal one. And all of the speakers, I learned so much from the erudite presentations today, and I'm really grateful. And to Busisiwe, I thank you for your courage to come here and explain as best you can what happened. I'm sure a lot of people will be comforted by what you said. Some will be skeptical, but that is the nature of the game. So let me just say that, and I'm going to try not to cover the ground that has already been covered, but I do want to say a few things that may require the elevating of our sights a little bit. So in a pandemic, there's recurring themes. We know, pandemics reveal the strictures in society. They amplify the problems of society. They accelerate the latent and emergent trends in society. And they also initiate new ways of thinking. This has been the case throughout history. Now, this pandemic experience has, however, revealed the rather tenuous hold of science on the public imagination. Even as many have been drawn to it and have been enlightened by it and have been fascinated by it, equally, there has been a large reluctance to accept it. And I think this is not the last event where, for example, we now at opposite ends with, say, the CGE, but this occurs in various levels of society as well. So, and it happens even among the great and the good, to the convenience really of populists. And, these people tend to exploit the fears and anxieties of people that pandemics generally create. And as a colleague reminded us recently, there's a lot of politics in science, but not much science in politics. It's often been enlisted, that is, science has often been enlisted in the service of the profane by the cunning, the ignorant, and the demagogues. It's been no different during this pandemic, when these forces have been unleashed right here in our country and around the world to great effect, all negative. It stems from a false belief that one is in a war or conflict with the virus. It's of course nothing of the sort, but it's in the martial language used to rally the people towards a particular political cause that is so damaging to the response. So 3 lessons quickly arise from this experience. First, be humble in the face of this virus. Do not try and enlist it to your agenda or to your cause, whatever that is. Do not exploit the fear it creates to reach your objectives. A former Chief Justice learned that to his great cost when he likened vaccines to devilish instruments. We did not relent. And we did not relent when the CGE made a major misstep here either. So that's the first lesson, be humble. Second, let reason, rationality, and science guide the response to this existential threat. To the authorities, that must be the golden rule, because the science is all that can be measured. Everything else can be dilated and twisted. to meet specific agendas and arguments. The application of the science has not been perfect. We know this, and nor should we expect it to be, because we have learned new things almost daily during this pandemic. And the only thing we have done right is to change our views in the light of that knowledge. Third, and lastly, the social and cultural tenets evoked by a calamity of this nature must be carefully parsed so that no toxic cultural or dangerous social trends are evoked as a result. To society's leaders, that must be the kernel of the wisdom that must guide their utterances and their actions. And in conclusion then, what learnings are there to leave to the denizens of the next decades in a world facing incredible odds, in which a collision of crises await us? There's the climate catastrophe and the decimation of the harmony of a biodiverse planet, of a biodiverse Earth, which we are learning is a planet-sized organism. Now, this crisis meets the crisis of a neoliberal capitalism. We are desperate and losing race by central banks and governments to maintain value in a fiat currency is a losing bet. When the 1% doubled its wealth and the bottom 50% more than halved its wealth, the situation is dire. And when these crises meet the waning capacity of states, the new crisis to care for the people, then the compound effect is severe. But it's when these crises collide with COVID-level pandemics, and they will come, we know that the threadbare fabric of civilization begins to unravel. So we've left the next generation a real fixer-upper here. But let me leave it on a higher note, because to those in power or who hold in their brief custody the power of the state, the relationship with the people must be most rigorously and judiciously mediated. The best protection of the people is by the people. Keep those in power at arm's length. Watch them like hawks. Never deposit your trust in them freely, nor auction your reason to them. The words of a feminist will close my input. Susan Sontag, feminist thinker and author. Her words are inspiring because they have the power, because that's how the power of governments and leaders and institutions can be mitigated and mediated. She says, and this is a message to the women of the world more than anyone else, who find themselves always with a short straw. Do stuff, be clenched, curious, not waiting for inspiration's shelf or society's kiss on your forehead. Pay attention. It's all about paying attention. It connects you with others. It makes you eager. Stay eager. Thank you very much.
Thank you, Aslam, for those really, really powerful words. And thank you also to all our presenters, panelists, and the delegates for the powerful messages that you have been sending through. For me, in simple language, what we have is this huge trust deficit in the country. It's being said so often that it's really starting to sound cliche. But I do feel it's important for organs of the state to recognize the trust deficit in them. Now, the Commission's statement has actually contributed further to eroding trust. And I hope, yes, the statement has been retracted, but I do hope that the Commission actually has some insight as to what it's done further with regard to eroding trust, something we just can't afford in this country any longer. In terms of social justice, Lebogang articulated it so well. We are so far lagging behind with regard to social justice and especially gender justice. So the Commission for Gender Equality as an organ of the state must be responsible for its mandate. And unfortunately, it has not responded responsibly, despite retracting its statement. But, the question has been asked, what has the CGE done for women thus far in the context of the pandemic? Let's just leave it to the pandemic. So, and we look at especially our vulnerable and indigent women in this country. What has it done? Its silence has been deafening. And I think in terms of the statement that it put out, there's no doubt, even though it retracted within a week, it definitely would have contributed to further vaccine hesitancy. And I think because of that, the CGE should take the lead in the fight of vaccine hesitancy and increase, and start work towards increasing vaccine confidence in our women. And Lebogang, I challenge you. We have experts, our clinicians, our scientists, collaborate with them. And I challenge you, I'm waiting for that phone call to the Medical Research Council, to Professor Glenda Gray by Monday morning. Let's work together. Work with us and we will work with you. And on that note, I want to thank everyone for attending, for their support of this important activity. And good night. Thank you.